Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Area of lung cancer management that has undergone a lot of rapid development is management of patients with earlier stage, that is, resectable lung cancer. We generally think of non-small cell lung cancer in blocks of, say, early stage that is able to go to surgery, locally advanced, typically stage 3 lung cancer, where maybe surgery is an option, but it's often managed with chemo and radiation in a combination, hopefully with a goal of curing it, and patients with more advanced disease that has spread to other parts of the body, known as metastatic advanced lung cancer, where our main treatment is whole body therapy, and it's not as it's not something where we can realistically anticipate treating to cure. But the biggest area of change in just the last 6 to 12 months in the field of lung cancer has been new options for treating patients with resectable lung cancer. Historically, we've had a standard for about 15 years where patients will have surgery up front in most cases, and then patients with higher risk disease, a cancer that the main cancer is 4 centimeters or larger, or has lymph node involvement, where the risk is high enough for the cancer to come back that we want to reduce that risk by giving a whole body therapy, systemic therapy, usually chemotherapy. And that is typically given as 4 cycles of IV therapy, given a cycle is typically 3 weeks. So you're talking about 12 weeks of therapy after the surgery. We have, in the last couple of years, had some advances where there could be a role for giving targeted therapy against what's called an EGFR mutation for years in patients who have an EGFR mutation identified on their tumor, and also a new potential role for giving immunotherapy for up to a year for a subset of patients otherwise. But the latest advance in early 2022 is the potential of giving chemo with immunotherapy before surgery. This concept is called neoadjuvant therapy. Adjuvant means helper. Neoadjuvant or new adjuvant is basically giving it before the surgery. And this is based on a clinical trial called Checkmate 816 that had some early data presented in 2021 and a publication in the very influential journal, New England Journal of Medicine, in 2022. And we've also seen more data presented on it. And what we've seen is that giving chemotherapy with a 2-drug combination that is so typical for lung cancer, along with the immunotherapy called nivolumab or Opdivo, for 3 cycles before planned surgery, leads to a very significant improvement in the probability that the cancer will shrink before surgery as assessed by CT scans. Also, a more than 10-fold increase in the chance of what is called a pathologic complete response, which means that looking under the microscope at the time of surgery, the pathologist can't find any evidence of any viable cancer. That only happens about 2.5% of the time when patients are given a few cycles of chemotherapy alone. But it's almost a quarter of the time when patients got chemotherapy combined combined with immunotherapy for these 3 cycles. That's a very exciting change. And what we've just seen in the newest data is that the patients who have had all of the cancer under the microscope eradicated, these patients with a pathologic complete response, have a much, much better chance of doing well for years to come, looking at what's called event-free survival, no cancer returning and not dying in the years after surgery, compared to the patients who still had viable cancer under the microscope. So this is an exciting change and is FDA approved now. So this is an option that is one to strongly consider if patients have a cancer that is staged 1B, 2, or 3A, and that is really a measure of how large the cancer is, where it is located, and how many lymph nodes are, or how big the lymph nodes are in the chest. So that is something that a surgeon and very possibly a medical oncologist would want to talk to you about. And one real appeal of doing the treatment up front is that you only are doing 2 months of treatment compared to adding a whole year of immunotherapy after the surgery. That saves side effects and time and cost for potentially a patient and the whole system. And it means not as much time being tied up getting treatments for lung cancer and being done with it after the surgery, very likely. Then there's the issue of more reliability of getting all of the treatment delivered if it's done before surgery. What we find is that patients are much more able to get all of the planned treatment if it's given as a relatively short course before surgery, then go on to surgery. Everyone's motivated for that. Problem is when you use the approach of starting with the surgery and then potentially go on to chemotherapy, a lot of patients don't go on to do that, whether that is because of complications from the surgery itself, just not feeling well, infection, whatever. A lot of things can happen, and then a lot of times patients will be less motivated once the cancer is out and they can't see the improvement of the treatment, and you're treating essentially blind compared to treating in the preoperative setting where you can see the effect of the treatment. And then there is that effect of preoperative versus postoperative. You can see the benefit of the treatment that a patient received if it's given preoperatively, and postoperatively, you really have no idea. So in the next few years, we will be getting more data on preoperative and postoperative approaches, but this option of 3 cycles of chemotherapy combined with Opdivo, also known as nivolumab, is now an FDA-approved option that is going to be a leading consideration for many patients with resectable lung cancer.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.